Next is the subluxated cataract. Light off. You can have a multiple type of subluxation, multiple grade of the subluxation. So rhexis should be away from area of jonular weakness, smallest possible incision to avoid the fluid egress, and same, avoid the collapse of anterior chamber. Viscoelastic should be used adequately. Use highly retentive viscoelastic should be used. It helps to tamponade the vitreous. Rhexis should start in the area of remote from the dialysis, 5.5 to 6 mm size. If extensive jonular weakness, you can do the CC by blade also. Hydrodetection should be careful. Nucleus freed maximally because there is a, you should avoid the stress on the jonule, so rotation should be totally free. So use hydrodissection more properly. Low vacuum, phacoemulsification, low flow, bottle height is reduced so there is a less turbulence. Decision regarding the surgical intervention depend on the area of jonular disinsertion. This is a small subluxation in the peripheral area, you can see. So you do the rhexis from the opposite side, slow hydrodissection. It is a simple case, can be managed without any CTR. You can see that the jonules are weak and there is a turbulence of the whole bag is there. You may insert the CTR or you may avoid, keep the haptic in the direction of jonular dehiscence. And once, if there is some small portion, you can put the intraocular lens in the place and then you can emulsify the nucleus. Because there is because jonules are weak, there will be much of the fluctuation in that area. Now, this is extensive 6 to 7 o'clock hours. Rhexis started from area where the jonules are healthy, slightly smaller rhexis. Cataract is soft, you can do. You can put the CTR earlier also, but I thought that the capsule, rest of the jonules are quite tough, so we put the CTR after the aspiration. You have to put the viscoelastic, especially viscod, to tamponade this portion of the vitreous. Importance of this tamponade is that vitreous should not come forward. Another thing, your nucleus fragment should not go beyond this. So then, insertion of the CTR. If you feel that bag is extended well, otherwise you have to suture, that I will show in another case. This is extensive scleral fixated. Same principle. It is just modification technique, so I just skip the rest of the procedure. Gentle phaco. Now, to avoid the fluctuation of bag, you can use the capsular hook so that keep your capsule straight. This should be not sharp because otherwise it will tear, and you can very well do the phacoemulsification because now your bag is stable. But once you remove this hook, again the bag will be loose, so you have to suture sclera. You have to fix it with the sclera. So you have to use the CTR, which we can suture with the, or you have to go for scleral fixated lens. So once you have done, you have to again go for this CTR, which is sutured to the sclera. You make a pocket here and suture that. Now, one of the subluxated cataract, just I want to show here is an important thing that another option we can go for is the scleral iris scleral lens. Once you have removed antivitrectomy, now the option either you can use scleral fixated or glued lens. Another is simple, is the iris scleral. How simple it is, you can see. One claw, hold it from other side. Another claw. And this is done. And another thing is one important, we can use this femto laser for, in cases of you are not able to do the rhexis properly. Okay, boss. Thank you. Thank you, boss.